دكاترة كتير دخلوا وعملوا ريجستريشن، وهم هيتابعوا الميتنج بتاعنا اونلاين. فدي اول مرة حاجة زي كده او اي شركة فارماسيوتيكال تعملها، فدي حاجة كويسة واي هوب ان هي تنجح وتحوز على اعجاب حضراتكم. هنعرض على حضراتكم بس 2 minutes movie على مينا فارم فارماسيوتيكالز. الفكرة بتاعت الفيلم دوكيومنتري موفي، الفكرة جت من ان في شركة بريتش ايرويز، شركة منتجة للافلام الدوكيومنتري على ايجيبت، اختارت مينا فارم as a national pharmaceutical company to represent the pharmaceutical industry in Egypt. ليه؟ لان احنا الشركة الوحيدة اللي فيها بايوتكنولوجي، مصنع بايوتكنولوجي في العاشر، واحنا بنقدم innovative affordable products for the Egyptian market. كل الطيارات الناشونال والانترناشونال. برحب بحضراتكم، اتفضلوا.
Mina Pharm is an industry-leading pharmaceuticals company with a proud heritage of over half a century of experience in delivering cutting-edge technologies to produce the highest quality medicines. Mina Pharm is breaking boundaries and challenging industry norms in the pursuit of excellence. To fulfill this purpose, a clear vision of future expansion has come to fruition through multiple alliances and partnerships with specialized companies around the world.
We at Mina Pharm established the first research community in Egypt and the Middle East. Our team is composed out of young, talented Egyptian scientists and European experts. Together, we develop high-quality and cost-effective genetically engineered drugs.
The development of complex genetically engineered medicines in Egypt is supported by Mina Pharm's German subsidiary, a global provider of intelligent proprietary technologies for the biotech industry at large, with a firm commitment to breaking down scientific and economic barriers.
There is substantial evidence that a new age is dawning for Egypt to offer exceptional opportunities, and Mina Pharm is perfectly positioned to ride into the future with life-saving and life-enhancing, innovative and yet affordable products.
Striking the balance between innovative and affordable medicines is the mantra at the company's core, allowing Mina Pharm to play an important social role by responding to the complex challenges of unmet medical needs of emerging countries. Mina Pharm's desire to overcome these challenges helps the dreams of the next generation to be fulfilled.
Now we will start our topics. Professor نشار، اتفضل حضرتك البرزنتيشن.
بسم الله الرحمن الرحيم. I would like to welcome all of you and I would like to thank Mina Pharm. الصوت هيوصل؟ شكرا. And today I will discuss with you the gonadotropin ovarian stimulation. I will address 11 items. I will start by the types of anovulation and what are the types of ovarian stimulation. What are the types of the gonadotropin? After that, how to select a patient for gonadotropin stimulation. What is the indication and the contraindication? What is the starting dose of gonadotropin? And at the end, protocols, monitoring results, and complications. Let us start by the types of. We have 4 types of anovulation. The first type, or WHO type 1, constitute 5%, and in which there is a decrease in the E2 and FSH. It is called hypogonadotropic hypoestrogenic. Type 2 constitute about 75%. It is the commonest type where the A2 is normal and also the FSH is normal. It is called normogonadotropic normoestrogenic. The third type is the hypergonadotropic hypoestrogenic, where the A2 is low and the FSH is high, and it constitutes about 10%. And the fourth type is the hyperprolactinemic type, constituting only about 5 to 10%, where the prolactin level is raised. What are the types of ovarian stimulation? We have 3 types of ovarian stimulation according to what is our objective and according to what is the type of our patient. Number 1, we have the induction of ovulation. Number 2, sober ovulation and the controlled ovarian stimulation. Today, I will address the first two types, the induction of ovulation and sober ovulation. And let us see what is the difference between the different 3 types. In the induction of ovulation, our patient is anovulatory, and our objective to get 1 mature follicle, while in the sober ovulation and controlled ovarian stimulation, our patient may be anovulatory or ovulatory, and our objective in the sober ovulation to get more than 1 mature follicle, while in the controlled ovarian stimulation, our objective is to get more than 3 mature follicles. The best example for the sober ovulation is the IUI and unexplained infertility. And for the controlled ovarian stimulation, the best example for this is the IVF. The third point to be addressed, what are the gonadotropin preparation? We have 3 types, the FSH, the LH, the HCG, and we have 2 types according to the source. Either it is from the urinary, the HMG, the highly purified HMG, the purified FSH, the highly purified FSH, and the urinary HCG, or the recombinant FSH, the recombinant HCG, and the recombinant LH. What is the recombinant FSH? Thanks to genetic engineering. By genetic engineering, we got the FSH isoform, which is less acidic and have a shorter half-life, and this will stimulate the estrogen secretion as or even more efficiently. Experts say, yes. What are the advantages of the recombinant FSH? There is absence of the urinary proteins. There is consistency. There is less batch-to-batch variability, and this will be reflected on our treatment. This is a gift or هدية لحضراتكم. All the urinary gonadotropin in the Egyptian market. This table shows the preparation, the trade name, the route of administration, the constituents, how much the urinary proteins, the FSH, LH, the price, and the producing company. And it is very important to know the economics of medicine, to know what is the available in the Egyptian market as HMG and what is its price, and the HCG and the highly purified HCG, and how they're constituting 95%, and it contains both the FSH and LH, and what is the price, and so on. And the highly purified, where is urinary is less than 0.001, and this is the price, and this is the producing company. What is about the recombinant gonadotropin available in the Egyptian market? We have the FSH, the Gonal F, the Purigon, and the Gonapure. And we should know the route of administration and how there is no urinary protein at all. And this is the constituents of the FSH and the producing company. And we should compare of the price and how is the Gonapure only 85, while this is for the 75 international unit, and for the 150, it is only 127. For the recombinant HCG, the Ovitrel, and the producing company, and the price, and the LH, the recombinant LH, the trade name, and the producing company. This is very important to select our medicine for treatment of our patient, to know the economics of the medicine. The fourth point to be addressed, patient selection. Before giving gonadotropin, we should do the basic investigations of infertility, the standard investigations of infertility, the routine investigations of infertility, which are three. Number one, the conventional semen analysis. Number two, the hysterosalpingiography. Number three, the mid-luteal progesterone. And if the patient is suffering from amenorrhea or galactorrhea, we should do the workup for amenorrhea or galactorrhea. The fourth point to be addressed, what are the indications of gonadotropin? As I mentioned, we have three indications for the gonadotropin, either to induce ovulation, or to use, or to do sober ovulation, or to do controlled ovarian stimulation. We will discuss the first indication, which is induction of ovulation. And for induction of ovulation, the best example of this is the hypogonadotropic hypogonadism, where the E2 is low and the FSH is low. And in this condition, the best, we should use a gonadotropin containing LH. We can use the HMG. But if you want to use the recombinant FSH, don't use it alone, but you should add to it LH. But may one ask what is meant by the low level of LH? It was defined by Spirov. If the level of LH, the basal level of LH is less than 3 international units per liter, we should give LH containing gonadotropin. In this type of anovulation, can we use Clomiphene citrate? Can we use letrozole? Can we use anastrozole? No, of no value at all. Why? Because in this condition, we want to have an intact and functionally the hypothalamic pituitary ovarian axis. And in this condition, Clomiphene citrate is not recommended at all and is not indicated for treatment of hypogonadotropic hypogonadism. The second indication for induction of ovulation is Clomiphene citrate resistance or Clomiphene citrate failure. What is meant by the resistance if there is no ovulation? And what is meant by failure if there is, in spite of ovulation, there is no pregnancy? As we know, the polycystic ovary syndrome is type 2 WHO. And we should not use gonadotropin as a first-line treatment of polycystic ovary syndrome, except in one condition. But why? It is not recommended to be used as a first-line treatment in polycystic ovary syndrome because there is a lack of oral formulation, it is expensive, it may be associated with a serious side effect, and we need a close monitoring with ultrasound. And that is not a first-line treatment. But if you are expecting a poor ovarian response, that's to say, the antral follicle count in both ovaries is less than 7. Don't waste the time of the patient by giving hard Clomiphene citrate alone. And in this condition, you should combine it with FSH. And this is the recommendation of the NICE, as we see here. If we are expecting a poor response, that's to say the antral follicle count is less than 6, we should add gonadotropin to clomiphene citrate from the start. It is not a first line, it is in this condition, a first line treatment for polycystic ovary syndrome. Just this is algorithm for management of polycystic ovary syndrome. Many of the patients of polycystic ovary syndrome are obese. That's to say the body mass index is more than 30. Or overweight. That's to say the body mass index is more than 25. And in this condition, we should instruct the patient to reduce her weight. And the first recommended medicine is clomiphene citrate. But if there is glucose intolerance or there is insulin resistance, we should add metformin. May one, how to diagnose glucose intolerance or insulin resistance? If the patient is obese, if the waist to hip ratio is more than 0.85, if the waist circumference is more than 100 centimeter, all if there is acanthosis nigricans, all of these are manifestation of insulin resistance. But we have a lab investigation to diagnose it. There is a very complicated test, but the most simple test, what is called the glucose, the fasting glucose insulin ratio, if it is less than 4.5, it is a diagnostic of insulin resistance. Let us go again to the treatment of the polycystic ovary syndrome to reduce the weight, to stop insulin resistance or glucose metformin. And we will wait for 3 cycles to get ovulation, or wait for 6 cycles to get a pregnancy. If there is no pregnancy or no ovulation, in this condition we have 2 options. Either laparoscopic ovarian drilling, yes, still there is, but we should know what is the appropriate methods for doing laparoscopic ovarian drilling. And it is also indicated if I cannot follow up the patient, or there is other indication, surgical indication. Otherwise, I will adopt and I will give the patient gonadotropin. And after that, I will wait for 6 cycles. If there is no pregnancy, don't waste the time of the patient. Direct for IVF. So this is the algorithm for management of polycystic ovary syndrome, reducing the weight, clomiphene citrate, add metformin, and then gonadotropin or laparoscopic ovarian drilling, and if there is no pregnancy, IVF. Just a hint, what is meant to condition? And it is defined when there is no ovulation with treatment of clomiphene citrate 100 milligram. In the past, we were giving the patient 5 tablets of clomiphene citrate, but this is not recommended. Milligram per day for 5 days. And the causes of clomiphene citrate resistance may be hyperandrogenism, obesity, or severe insulin resistance. The clomiphene citrate failure, that is that in spite of ovulation, there is no pregnancy. And this may be attributed to the anti-estrogenic effect of the clomiphene citrate, its effect on the endometrium, decreasing its thickness, or its effect on the mucus, making it more viscid, or the half-life of the clomiphene citrate, which is long. All of this will, and it may cause deficient corpus luteum function. May one, how this? Clomiphene citrate can be used for treatment of luteal phase defect, and it may cause luteal phase defect when it is given with a higher doses, and that's why the recommended dose is 100 milligram daily only. The dosage of gonadotropin in this condition, we should use the minimal effective dose. Not only this, but also we should monitor our patient to adjust the dose and to time the ovulation. Then, in this condition, is luteal phase support is mandatory? The answer, no. And the only luteal phase support is indicated if we are using evidence of luteal phase defect. And in this condition, the best is progesterone. The second, we are talking about the indications of gonadotropin. And we mentioned that we have 3 indications: induction of ovulation, the hypogonadotropic hypogonadism, and the clomiphene citrate failure or resistance, or from the start if we are expecting a poor ovarian response. The second indication is superovulation, and our objective in this condition to get more than one mature follicle. And the best example for this is unexplained infertility. But what is meant by unexplained infertility? Unexplained infertility is diagnosed when the 3 basic investigations of infertility are normal. This is to say, the mid-luteal progesterone, the hysterosalpingography, the conventional semen analysis. And our objective in this condition, not to get one follicle. If you got one follicle, you did nothing. And that's why the oral ovulating drugs is not recommended to be used in unexplained infertility. As we see here, there is a comparative study between the clomiphene citrate and the expectant management, and found there is no difference at all. Even the expectant management was associated with more pregnancy rate. And there is what is called the number needed to treat. How many patients should be treated with clomiphene citrate in unexplained infertility to get one pregnancy? 40 patients to be treated to get one pregnancy. Not only this, but it is recommended by the ONICE, don't offer any oral ovulating drugs. May one say, I will not use the clomiphene citrate, I will use the letrozole in unexplained infertility. It is also not recommended to be used in unexplained infertility. But in this condition, we should use the FSH, because the comparative study between FSH and the clomiphene citrate in management of unexplained infertility found that there is a significant higher clinical pregnancy rate reaching 25% versus 8% for clomiphene citrate. May we will add letrozole to FSH. We will get better results. The FSH dose will be reduced and the clinical pregnancy rate will be increased. This is algorithm for management of the unexplained infertility. The management of unexplained infertility depends on 3 factors. What is the duration of infertility, the age of the patient, and what is our resources. This is very important. And this, if you see here, if the age between 35 before or below 35 years and duration of infertility less than 2 years, expectant management for 2 years. If there is no pregnancy, we will do sober ovulation with FSH for up to 6 cycles, but nobody will wait for this 6 cycle. If the duration of infertility is more than 2 years, we will directly do sober ovulation with FSH for up to 4 cycles. But if the age between 35 and 39 years and duration of fertility is more than 1 year, we will do sober ovulation and IUI for 2 cycles. But if the patient above the age of 40, only 1 trial of sober ovulation and IUI, 1 only. And if there is no pregnancy, direct for IVF. Don't waste the critical time for this patient, and we should direct her for IVF. The second indication for gonadotropin in superovulation is IUI, and it was found that most effective when we are using the FSH. And IUI with gonadotropin, don't do IUI with any oral ovulating drugs. Why? As we see here, according to the ESHRI, the pregnancy rate is 12% per cycle, but there is increase the rate of multiple pregnancy. The Cochrane also recommending to use IUI with FSH because this will increase the clinical pregnancy rate compared with timed intercourse or any stimulated cycles with oral ovulating drugs. But the ONICE in 2013 against IUI completely, and they put only 3 indications for IUI. If there is a social indication, cultural or religious objections for IVF. But this is not suitable for the low-resource countries like Egypt. And still, the IUI has its role in management of unexplained infertility, mild endometriosis, and mild male factor infertility in the low-resource countries. Of course, we should monitor the patient taking gonadotropin and to avoid the risk of multiple pregnancy, which is more than when gonadotropin is given for a patient with clomiphene citrate resistance. And in the past, the recommendation for luteal phase support, there was no recommendation to give a luteal phase support. But recently, there is a recommendation to give a luteal phase support in IUI, because according to this meta-analysis, they found that there is an increase in the clinical pregnancy rate, especially if you are giving gonadotropin, and especially if there is a history of unexplained repeated miscarriage or there is a corpus luteum defect. So in IUI, nowadays, it is recommended to give a luteal phase support in the form of a vaginal progesterone. And this is also table of all the progestogen in the Egyptian market. And according to this table, what is the form, oral or intramuscular, vaginal or rectal, vaginal or oral, and so on. What is the generic name, how many milligram, what is the form, what is the price, and what is the producing company. I think it is very valuable in our practice to know the economics of medicine to give it to our patient. The third indication of the gonadotropin, we mentioned that the first indication is induction of ovulation, the second is superovulation, and third indication is controlled ovarian stimulation, which is not our subject today. What are the contraindications of the gonadotropin? The contraindications of gonadotropin are rare. First, if there is hypersensitivity to gonadotropin. Second, if there is an ovarian, uterine, or breast cancer. In this condition, it's contraindicated to give gonadotropin. If there is a tumor in the hypothalamus or in the pituitary gland, if there is ovarian enlargement, except, of course, polycystic ovary syndrome, if there is an ovarian cyst, but there is a cutoff level for using gonadotropin in the presence of ovarian cyst. If the ovarian cyst is 3 centimeters or less, go ahead and give gonadotropin. But if it is more than this, it is better to stop or not to give gonadotropin until it is treated. Of course, if there is pregnancy or lactation, or if there is uterine bleeding of unknown etiology, in this condition, we should not give gonadotropin. The seventh point to be addressed, what is the starting dose of gonadotropin? The starting dose of gonadotropin depends on many factors. Number one, what is my objective? I want to induce ovulation, or I want to super ovulate or I want to do a controlled ovarian stimulation. The second, what is the age of the patient? Of course, increasing the age of the patient, we should increase the dose of the starting dose of gonadotropin. What is the body mass index? If the body mass index is higher than 30, we should increase the dose of gonadotropin. But please, after exclusion of polycystic ovary syndrome. If there is a polycystic ovary syndrome, we should start with a 1 vial, or even, as I will mention here, they are starting by 37.5, half ampoule of gonadotropin. What is the ovarian reserve? In the past, we have a lot of ovarian reserve tests, but nowadays we have only 3: the antral follicle count, the anti-mullerian hormone, and the basal FSH. And lastly, we should take a history from the patient and to know what is the previous response to the gonadotropin. Don't neglect this. And it will direct to what is the proper use or the proper dose of the gonadotropin to be used. Our goals is to maximize the benefits, that's to say to have a singleton live birth at term and to minimize the risk of ovarian hyperstimulation syndrome, multiple pregnancy, and the cycle cancellation. And we should recognize what is the type of our patient. If our patient is polycystic ovary syndrome, which is increasing nowadays, constituting about 60% according to some studies of our patient, or a patient of poor response, which according to some studies constituting about 40% of our patient. And this is the NICE cut-off level for the ovarian reserve test. As I mentioned, we have 3: the total antral follicle count, and this is very important and also very sensitive, and it should be evaluated in certain condition. And the low response, if the total antral follicle count in both ovaries is 4 or less, and the high response if it is more than 16. And between 4 and 16, it is the normal response. For the anti-mullerian hormone, if it is 0.5 or less, high response if it is more than 4. For the basal FSH, that's to say day 3 FSH, if low response when it is 10 international unit, and the high response if it is 4. But please be patient. Don't do cycle cancellation except after 10 days. And sometimes the dominant follicle appear during the first treatment cycle with a low dose gonadotropin. The next point to be addressed, what are the protocols of gonadotropin? We have 3 protocols: the step-up protocol, the step-down protocol, the step-up, step-down. But the first one, which is nowadays used, and the step-up, we have the conventional or the standard, the low dose, and the chronic low dose. Also, the last 2 which are used nowadays. Let us see what is the step-up and what is the principle of this. Our principle to increase the FSH, reaching the FSH threshold, and after that to maintain the same dose of FSH. The conventional, that's to say this was the standard which in the past, which is not recommended nowadays, to start by 2 amps of gonadotropin or FSH, that's to say 150 international units per day, and after 5 days to increase the dose, and after 3 or 5 days we will increase the dose, and this will be associated with a high incidence of ovarian hyperstimulation syndrome and excessive follicle development, and that's why it is not longer recommended. And this is an example of the standard protocol, step-up protocol, starting with 2 FSH from the day 3, and after 5 days in the day 7, if we got a follicle more than 12 millimeter, we will maintain the same dose. But if not, we will increase the dose by 75 international unit for 3 more days and so on. This is not recommended because it is associated with a high incidence of ovarian hyperstimulation syndrome. The low dose which is used, the starting dose is 75 international unit, and the duration of starting dose is only 5 to 7 days. And if there is no follicular development, we will increase by 100%. That's to say, if we are giving 1 ampule, we will increase it to 2 ampoules. And the monoovulation is got in 70% of cases, and the multiple pregnancy is about 6% of cases, and the ovarian hyperstimulation syndrome is less than 1%. And this is an example of the low dose protocol. We are starting from the day 3 by 1 ampule, and will for 5 days, and after it's day 7, we will assess if we got a follicle more than 12 millimeter or not. If we got it, we will continue the same dose. If we didn't get it, we will increase to 150 and for 1 week and so on. But in cases of polycystic ovary syndrome with a high incidence of ovarian hyperstimulation syndrome, which is a life-threatening condition, which is an iatrogenic complication. In this condition, the starting dose may be half ampule, 37.5 or maximum 75 international unit. And the duration of the starting dose, 14 days. Don't increase in the chronic low dose protocol except after 2 weeks. And the increment by 50%, not by 100%. Of course, by doing this, the incidence of ovarian hyperstimulation syndrome is markedly decreased. And this is an example of we will start by half ampule, and after 14 days, after 2 weeks, if we didn't get the required response, we will increase to 1 ampule, and after we will wait for 7 days, we will increase by half ampule, and so on, reaching to the maximum dose is 225 international unit after 49 weeks. Who agree for this? But this is what is written and what is prescribed. I don't agree with this. What is the condition of the endometrium in this condition? So we should know the maximum days of gonadotropin stimulation. For me, it is 21 days. If it is, I didn't get my required response, I will cancel the cycle and start in the next cycle with doubling the starting dose of gonadotropin. And that's why there is many modification of the chronic low dose protocol, but this is what is prescribed by White et al. For the chronic low dose protocol up to 49 days. This is another modification, and only reaching it after 21 days. Monitoring of gonadotropin stimulation is very important, and we have 2 modalities for monitoring of the gonadotropin stimulation. We have the transvaginal ultrasound, and we have the E2. And for the transvaginal ultrasound, it should be done baseline, that's to say in the day 2 or day 3. And in this condition, we want to exclude the presence of any ovarian cyst, and as I mentioned, if it is more than 3 centimeters, this will decrease the fecundity, and we should postpone gonadotropin. Also, to assess the antral follicle count, and so we can expect what is the ovarian response, and we can determine what is the proper start. And this is the example of the antral follicle count. I will do transvaginal ultrasound in the right and the left just to get the largest diameter of the ovary, and you do what's called banning, and to count how many follicles measuring 2 to 10 millimeters in the right and the left. After that, in the day 5 or 6 of stimulation, we do ultrasonography, and to repeat it every 2 to 3 days according to the size of the leading follicle until there is a follicle 18 millimeter in diameter. And in every time, we should assess the follicles and the endometrial thickness. The follicles as regards the number and the size, and we should document all the follicles above or bigger than 10 millimeter. When we got 1 to 2 follicles, mature follicles, 18 to 20 millimeter, trigger with HCG. And please ask the patient to have a sexual intercourse in the day of administration of HCG. The pregnancy rate after ovulation is 0. The sexual intercourse in the day after ovulation is 0. There is no probability at all. This is a common mistake. خلاص, after rupture of the follicle, if there is any sexual intercourse, the probability of pregnancy is 0. Why? Because the life of the ovum is only 12 hours. And also there is a swift, very rapid changes in the cervical mucus after rupture of the follicle. And so we should recommend the sexual intercourse to on the day of HCG before the rupture of the follicle. When we got 4 follicles more than 14 millimeters, and we are doing now superovulation, not we are doing controlled ovarian stimulation. In this condition, we should stop stimulation and stop HCG. But may I ask you, what you are expecting if you are using Clomiphene citrate, the size of the mature follicle? And if you are using gonadotropin, what is the size of the mature follicle? May one, we are using gonadotropin, so the size of the mature follicle is larger. No, the answer with Clomiphene citrate follicles matures at 18 to 20 millimeter, while the gonadotropin follicle matures at 15 to 18 millimeter. This is an example of the folliculometry by the transvaginal ultrasound and one mature follicle. And this is an example of ovarian hyperstimulation syndrome. Not only the assessment of the follicle, but also we should assess the endometrial thickness in the longitudinal scan of the uterus and to measure the endometrial thickness. And if it is less than 6 millimeters, the probability of pregnancy is very low. But the best is between 9 and 10 or more. The chance of pregnancy is great. And also, as we mentioned, the mature follicle from 18 to 20 or even 21. And in this condition, if you are using IUI, please try to assess the endometrial thickness, because it is maybe the endometrial appearance and thickness more important than the follicular side for HCG administration. The second modality for monitoring of the gonadotropin is the use of the E2. And we have a cutoff level. If it is in the day of HCG is less than 200, the pregnancy is rare. If it is from 500 to 1,000, this is optimal for a pregnancy. But if it is from 1,500 to 2,000, there is a significant risk of ovarian hyperstimulation syndrome. If it is more than 2,000, and again, we are inducing ovulation, or doing superovulation. We are not using a controlled ovarian stimulation. The cutoff level for the A2 is quite different. But if you are doing a superovulation or induction ovulation and we have a 2000 picogram per mil, HCG should not given and the cycle should be cancelled. What is the pregnancy rate? The pregnancy rate according to the indication. In the case of the hypogonadotropic hypogonadism, after 6 cycles of gonadotropin, it is very high, 90%, while in clomiphene citrate resistance and ovulation, it is after 6 cycles, it is from 30 to 60%. I think we missed one slide about this is the result. في واحدة زي sorry. What are the results of the gonadotropin? The results of the gonadotropin ovulation in 90%. The pregnancy, as I mentioned, according to the indication, reaching 90% in hypogonadotropic hypogonadism after 6 cycles. The miscarriage is slightly increased, and this may be attributed to the most of the patients with advanced age, and most of the patients are obese, and that's why the miscarriage rate is 20-25%. The congenital anomalies, there is no increase in the congenital anomalies at all with the use of the gonadotropin. What are the complications? This is the last item to be addressed. The multiple pregnancy, according to the protocol we are using, if low dose protocol, it is less than 6%. If we are using the conventional dose protocol, which is not recommended, the multiple pregnancy is very high, 37%. The ovarian hyperstimulation syndrome, again, according to the protocol we are using, if it is a low dose protocol, it is less than 1%. If the conventional dose protocol, which is not recommended, it is about 4.6%. Breast and ovarian cancer, there is no increase at all with the use of the gonadotropin. Maybe a local allergic reaction, but it is rare. To come to the conclusion, number one, our intended goal is unifollicular ovulation or superovulation. We have 3 main preparations: FSH, LH, and HCG. We have 2 types, urinary and recombinant. Basic investigation of infertility should be done. The indications of gonadotropin are hypogonadotropic hypogonadism, clomiphene citrate failure or resistance, unexplained infertility, and IUI. Contraindications of gonadotropin are rare. Step-up chronic low-dose protocol is recommended in polycystic ovary syndrome. Ultrasonography monitoring is mandatory for gonadotropin stimulation. The ovulation rate is 90%, pregnancy rate 30 to 90%, miscarriage 20%. The complications are ovarian hyperstimulation syndrome and multiple pregnancy. And shukran, you can get this lecture on my scientific Facebook page, Abu Bakr al-Nashar lecture. You will find this lecture and also about 300 lectures. شكرا. نسمح بالأسئلة دلوقتي ولا بعد كده؟ في الآخر؟ طيب أنا أحب أبدأ من الآخر. الدكتور أشرف، أي سؤال أو كومنت الدكتور أشرف؟ دكتور حسام. طيب صفوف الأخرانية، اتفضل يا بيه. اتفضل يا بيه. اتفضل يا بيه. introduce yourself please. الدكتور احمد رماح، استاذ امراض النساء والولاده بكليه طب الازهر. اهلا وسهلا دكتور احمد.
بشكرك جدا دكتور ابو بكر، دايما بنستمتع بمحاضراتك.
ده من ذوقك يا دكتور احمد.
قيمه وبتزود معلوماتنا.
الله يخليك.
وبنشكرك جدا. هو بس في 2 points to be emphasized.
اتفضل حضرتك.
وحضرتك قلتها طبعا. اولا we should not give gonadotropins without prior HCG.
أيوة.
Nowadays we're seeing young fellows they are giving HMG without doing hysterosalpingogram. So hysterosalpingogram is mandatory.
احنا قلنا بان في انا complaining of for amenorrhea galoptoria should be done. ايه تاني يا دكتور احمد؟
Second point ان ما فيش حاجه اسمها gonadotropins every other day. If we are
Yes.
giving gonadotropins we should be given every day.
ده كلام سليم. I
برضو
quite
young
agree with
fellows
you.
they are giving
يعني ان احنا even لو انت بتدي هاف امبول ممكن بانك انت تديها ديلي، لكن الحكايه every other day ديت نوت ريكومند. شكرا يا دكتور احمد.
معلش 2 points.
اتفضل.
Third point you said برضه folliculometry is mandatory. We should not give gonadotropins without doing folliculometry.
Yes.
And timing of HCG as you said Dr. Bak and with the follicle reaching 18 and more.
شكرا. I quite agree with you دكتور احمد استاذ امراض نساء. الصف اللي بعده. طيب الصف اللي بعده خلينا بس ايه كده اتفضل يا بيه. عرف نفسك لو سمحت.
حضرتك احمد هجرس، مدرس امراض نساء كليه طب جامعه طنطا.
يا اهلا وسهلا بيك دكتور احمد.
هو نشكر حضرتك جدا على المحاضره الفيري انترستنج دي، بس كنت عايز توضح من حاجه كنت عارفها من دكتور هشام رئيس القسم عندنا، كان قال لنا ان الموست دينجرس هي الجروينج فوليكلز مش
ان هو ايه بيه؟
during الفوليكلومتري اللي احنا بنعمله الموست ريسكي اللي هي الجروينج فوليكلز، لان هي دي اللي بتطلع
الكلام ده كلام صح جدا، واحنا وي كان الابوريت ذيس اند هايلايت. تخاف دايما من الانترميديت فوليكلز،
هي دي اللي بتطلع استروجين عالي.
خلاص هي ديت اللي هي ما يحصلهاش رابشر، هي ديت اللي هتعمل اوفيريان هايبوستيميشن سندروم. يعني ازاي؟ يعني الحاجات اللي هي 14 و15 13 دي اللي تخاف منها، واخد بال حضرتك؟ بس احنا عندنا كرايتيريا فور ستوب الاتش اس جي في السوبر اوفيليشن والاندكشن اوفيليشن مختلفه تماما لو انت بتعمل كنترولد اوفيريان ستيميوليشن. يعني في لما اجي اقول كده لا اما بعد 20 او اعد 15 من اللي حضرتك بتقول عليهم دول. يعني شكرا دكتور احمد.
شكرا.
الصف اللي بعده. الصف اللي بعده اتفضل يا بيه.
دكتور احمد الحلوجي، مدرس امراض نساء جامعه طنطا.
يا اهلا وسهلا.
شكر موصول لحضرتك طبعا.
شكرا دكتور احمد.
وانا سؤالي عايز استفيد من خبره حضرتك. احنا بنشوف كتير في البريسكريبشنز اللي بتجي لنا من اساتذتنا اليوز اوف 2 كومباينيشنز اوف انتي استروجين، زي نستخدم كلوميد مع التاموكسفين، نستخدم كلوميد مع الاترزول. فالحقيقه انا دورت في الليتريتشر ما لقيتش.
لا هي كانت في دراسه يابانيه ايام زمان.
اتفضل.
لكن ديت نوت كونفيرمد وفيها ايفيدنس بيزد بان هو زير از نو ديفرنس اتول، واخد بال حضرتك؟ ان هم كان يستخدم واحده كلوميفين ستريت واحده نولفادكس، ويقول لك بان انا اي ويل جيت بيتر ريزلتس على اساس بان هو ده يعني ما بزودش الانتي استروجينيك افكت. لكن احنا دلوقتي ده احنا قلنا بان الماكسيمم دوز 100 مللي جرام ديلي، واخد بال حضرتك؟ لكن في دراسه يابانيه يمكن من 20 سنه ولا من 15 سنه كانت بتقول هذا الكلام. اي سؤال تاني من الصف اللي بعده؟ دكتور عبد الجواد متولي، استاذ امراض النساء بكليه طب المنصوره.
بنكرر شكرنا للشركه والاستاذ دكتور ابو بكر النشار. والحقيقه انا شرفت ان كنت من اول الناس اللي استخدموا الجونا بيور في المنصوره، يمكن حتى من قبل ما ينزل في السوق، هو لسه عينات
قبل ما ينزل من السوق. كنت بتجيبه
قبل ما ينزل فورسيل، يعني هو لسه في الاول خالص. وكانت نتائجه معايا كويسه. يمكن لاحظت بس ان الجونا بيور 150 احسن كتير حتى من 2 امبولز 75. يعني ال 75
طيب احنا بقى هنا نستغل الفرصه دي وعايزين حد من الشركه يعمل كومنت على هذا الكلام.
اما اكمل بس بقيه الاسئله.
ايوه.
فبالحقيقه بالنسبه لحضرتك طبعا استمتعنا بالمحاضره القيمه. وفيه 1 كومنت و1 كويشن.
اتفضل.
As regard the question, what about your experience about use of serum like climidinone with clomiphene citrate?
ايوه.
It add benefits for pregnancy rate or not?
لا هو ما زودش البريجنسي ريت ولا حاجه خالص.
اصل كان في دراسات اتعملت يعني في السوق،
يعني هي لسه يعني
بيستخدموها من اليوم الثاني لليوم لغايه يوم الاتش سي جي وقالوا ان هو حسن النتائج شويه از ريجارد الاندوميتريال سيكنس واز
انت حضرتك بتتكلم على الستارتنج دوز اوف كلوميفين ستريت.
نو، مع الكلوميفين ستريت بيبداوا يستخدموا الكليمادينون قرصين كل يوم مرتين.
لا الكلام ده نوت ايفيدنس بيزد، وهو ده عباره عن فايتو استروجين رايت، وما وجدوش بان هو بيزود ولا حاجه خالص. اتفضل السؤال اللي بعده.
As regard the contraindication of the use of gonadotropins in uterine and breast cancer.
Yes.
الحقيقه ما هوش absolute contraindication، يعني it is a relative contraindication.
Yes.
احنا في حالات بنشوفها endometrial cancer in young age.
What's meant by a relative contraindication?
Yes, relative contraindication. But stage 1A grade 1 you can do endometrial curettage and give one cycle each gonadotropins and IVF or ICSI.
شكرا.
Then
شكرين جدا.
we have faced with a patient 24 years with endometrial cancer in polycystic ovarian patient. Also, after about 3 years of treatment of breast cancer, particularly if it is estrogen and progesterone negative, we can use gonadotropins for short duration.
شكرا. شكرين جدا جدا. دكتورة الأستاذة الدكتورة عفاف إسماعيل، أستاذة أمراض النساء والولادة بكلية طب الأزهر. أهلا وسهلا دكتورة.
Thank you very much for the valuable lecture as usual.
شكرا.
عفوا. بالنسبة للكومنت بتاع الزميل اللي هو اليوز اوف anti estrogenic medicine in induction of ovulation، لما بنستعمل حاجتين like Clomiphene citrate and Nolvadex or whatever، هو بيستعمله التاني الحقيقة علشان بيعمل improvement للسيرفايكال ميوكس اللي بيسببه الكلوميفين ستريت، بيعمل ستيكي اور
يقللوا الافكت بتاع الكلوميفين ستريت.
الافكت بتاع
بالتاكيد صح.
فهنا بيحسن شويه الانسيدنس اوف fertilization
Yes.
and pregnancy and
Yes.
please I would like to ask what is meant by patch to patch variability.
Yes. This is very important and this is what is the advantages of the recombinant FSH. لما احنا بنستخدم الاتش ام جي ونقول بان هي ديت عباره عن 75 و75 دولت مش مظبوطين فعلا، ان هم 75 ممكن يكونوا اكتر وممكن يكونوا اقل. And this explain why in some conditions in you got a very nice or a very good response والother condition in spite of using the same dose بتحصلي على نتيجه اقل. شكرا لهذا السؤال.
Please بالنسبه للسلايدز اللي كان فيها types of gonadotropins, I think Merionel usually we use in intramuscular use, not subcutaneous, and I think it's under IPSA construction or something like that, because I think it was written subcutaneous. Are you use this as subcutaneous or intramuscular?
المكتوب في الجدول بان هو
المكتوب في الجدول
subcutaneous or intramuscular.
No, subcutaneous only.
Subcutaneous only.
فبليز
لا, it can be used both.
Can
Yes.
I don't know. I would like to ask about something here. بالنسبة the place of gonadotropins in endometriotic cysts. For example, if it's plus or minus 5 cm, could be used or not? Endometriotic cysts.
Cyst, yes.
And unfortunately, it is increasing nowadays.
Yes.
And there is debate about it.
Yes, it can be used, right? And this depends on what is the management of endometriotic cyst. If you are doing now IVF, the recommendation don't touch the endometriosis except if it's causing pain or hindering the oocyte retrieval. Right? And the best treatment for this condition is the extended down regulation. That's to say we will give a down regulation for 3 months and after that to give the gonadotropin.
Thank you very much.
شكرا. سؤال اتفضلي الدكتورة، عرفي نفسك.
إزيس وهبة كونسلتنت وزارة الصحة.
اهلا وسهلا دكتورة إزيس.
دلوقتي واحنا بنعمل مونيتورنج للفوليكل بلاقي فوليكلز حلوة قوي والاقي الاندوميتريوم فيري ويك. How can I solve this problem?
انت في اليوم الكام؟
Day 8. وصلت مثلا 14 16.
كويس.
And the endometrium is very thin, maybe 2 3
It's very thin. In this condition there is many modalities for treatment of the thin endometrium.
Yeah.
احدها ان انا ادي لو دوز استروجين، احدها ان انا ادي بنتكسوفيلين. وبالمناسبه معلش انا هخرج عن الموضوع شويه بعد اذنك دكتوره. البنتكسوفيلين اللي هو افيلابل ان ذا ماركت في شكل الترينتال والبيكسال والحاجات دي وفيري تشيب. according to the evidence is very valuable in management of polycystic ovary syndrome. and also انا بعمل محاضره دلوقتي على الانتي اوكسيدانت ان انفيرتيليتي اند اي ار تي، ووجدت بان البنتكسوفيلين ده له دور كويس قوي، وهو كمان له دور في الميل فاكتور انفيرتيليتي الوحيد اللي له من كل ده. انا هرجع لسؤال حضرتك تاني. فوجدوا بان هو وبيستخدموه كمان في الاندوميتريوزس يا دكتوره، وفي دراسات قديمه عليه. فاحنا عندنا اكثر من طريقه علشان نزود السيكنس اوف اندوميتريوم، زي ما قلت لسيادتك بان احنا لو دوز استروجين، ان احنا ندي البنتكسوفيلين، ان احنا ندي الفياجرا، واخده بال حضرتك، ان احنا نشوف ايه الدراج اللي احنا استخدمناه. لو كنا مستخدمين الكلوميفين ستريت ما نستخدموش خالص، ونستخدمت حاجه زي الدكتوره عفاف ما قالت اللي هي ملهاش انتي استروجينيك افكت على الاندوميتريوم. شكرا. اتفضل الدكتور ايهاب سليمان، استاذ امراض النساء والولاده بكليه طب القاهره.
معلش انا ليا تعليق بس على اللي حضرتك قلتيها دكتوره ازيس، وفي نفس الوقت انا عايز اسال الدكتوره ابو بكر على سؤال بعد كده. حضرتك قلتي thin by day 8-7 and I believe this is too early to judge the endometrium. Maybe the woman can have her menstruation تقعد 4-5-6 أيام، بعدين you are judging the thickness of the endometrium by day 8. This is too early. You should judge the thickness pre-ovulatory in the late proliferative phase and not that early. I think this is
طبعا I quite agree. This is a very important practical point. ان احنا الداي اوف اتش سي جي ان احنا بنعمل اسسمنت اوف الاندوميتريوم. اتفضل دكتور ايهاب.
The question اللي انا بس كنت عايز اساله حضرتك دكتور ابو بكر، وحضرتك بتقول البرزنتيشن كان في من الحاجات contraindications of gonadotropins. One of them was hypothalamic and pituitary tumors. I really don't understand why. Why not to give gonadotropins?
Maybe it will increase the size of this tumor, or it may mask the diagnosis of this diagnosis. I think so. This is the يعني حاجة life-threatening condition like this. I think we should take it in very cautiously and not to give. It may have an effect on the hypothalamic because it will act on this axis.
Thank you, Dr. Abar.
اتفضل.
حسن هاشم، مدرس امراض نساء ساوث فالي يونيفرستي.
منين يا بيه؟
ساوث فالي يونيفرستي هنا.
اهلا وسهلا جنوب الوادي.
اهلا وسهلا. كنت بسأل حضرتك عن الرول اوف gonadotropins in cases with short proliferative phase او short follicular phase، اللي بتبقى short follicular phase cases بتبقى الاوفيوليشن بتاعها بيحصل على day 8 day 9 day.
الكلام ده كلام بنقوله في المحاضره بتاعه الريبيتد بريجننسي لوس الانكسبليند. في ناس بيستخدموا الجونادوتروبين، واخد بال حضرتك، لكن there is no evidence. هي عباره عن observational study. بيستخدموا فعلا الجونادوتروبين لما يبقى في ريبيتد مسكاريج، واخد بال حضرتك، بهذا الهدف ان هو one of the doubtful causes of repeated miscarriage is اليوتيال phase defect. شكرا. خلاص. في
طيب نحب نشكر حضراتكم على حضوركم معانا. مع حضراتكم ريموت ليه دعوه بالريبلاي بتاع الانسرز بتاع البرزنتيشن بتاع الدكتور ايهاب، فيا ريت حضراتكم يعني تستخدموه. هو احنا عاملين زي ديمو بسيط عشان خاطر نتاكد انه شغال. سؤال يعني بسيط، حضراتكم هتفتحوا الريموت كنترول من الزرار اللي تحت، باور اللي تحت، وبعد كده حضراتكم تختاروا اجابه السؤال زي ما تحبوا 1 2 3 4 5 او A B C D. في سؤال كده بسيط بعيدا عن الاسئله، مجرد عشان تو تيست من غير ما يعني ما نحرج، فحضراتكم لو تحبوا تردوا عليه هيبقى بالنسبه لنا تيست، وبنحب نشوف ان هو جهاز شغال. بليز فوت.
What is your field of interest؟ الأول سوري أنا سألت السؤال على طول، بس أنا I would like just to make an introduction. sorry. First of all, good evening, everybody. Second, I would like to send my compliments and gratitude to all colleagues participating in this nice event. And I believe it is of value to gather every now and then in meetings, seminars, congresses, and to share our clinical experience with each other. And I cannot miss this opportunity to thank Mina Farm with its professional and active staff and team, whom I really consider my friends and not just the team, for their effort in organizing these nice scientific gatherings, and this is one of them for sure, in an effort to upgrade and deliver the state-of-the-art scientific knowledge and practice. And قبل ما ابتدي التوك او البرزنتيشن بس هنجرب التست للريموت اللي هندوس عليه واسالكم 3 questions. What is your field of interest? Is it gynecology? Is it in vitro fertilization, or both? كده مظبوط؟ Okay. My presentation today is about actually an interesting case. It's a case presentation. كلنا بنقابل unusual cases. ممكن تكون rare, ممكن مش تكون مش ناشئة قبل كده. And I believe it is nice to make a debate and a discussion according to your experience or inexperience about some cases that can confront us during our practice. والنهارده this case presentation is related to some of the undesirable consequences of ovulation induction. فين اللي بيغير؟ هو this case is about a nice lady. She's 26 years old. Actually, she's very nice. أنا كنت مسميها the happy lady because she was always smiling. She's a very nice lady. And she's been complaining of infertility for 2 years. By history, she had regular sexual life. And when I mean the regular sexual life, the average is about 2 to 3 times per week. And she had regular cycles. Her body mass index was 24. I think this presentation is not the up-to-date one, the one I gave you in the morning. No, I think so. I think so. It's not. Can I use my? This is not the case. This is not one يا راجل. في some changes كده عملتها أخدتها. Okay. المهم anyway it's not written. هي جايه بتشتكي من infertility for 2 years. By evaluation الهيستوري بتاعها كان there was nothing abnormal. كانت عامله هرمونال بروفايل. It was all normal. كان ميد لوتيال بروجسترون normal above 10. البرولاكتين بتاعها كان in the normal range. عملت لها الترا ساوند. الانترا follicle count كان about 16. She had no pelvic pathology. The uterus was normal. Everything was fine. كانت مديه هيستوري ان she عملت diagnostic laparoscopy من 6 months ago, and the doctor said it was all perfect. The pelvis was fine. The only problem was that her husband had mild asthenospermia, and the count was fine. But asthenospermia, the progressive motility was about 25%. The last one قبليه كان أقل من كده. المهم هو the problem was the only thing was إن هو كان في mild asthenospermia. So the question number 1 in this case, as I mentioned, her checkup was okay. Only thing was she had mild asthenospermia. In this situation, لو patient دي جات لكم انتوا, what would be your next appropriate management? Would you proceed for assisted reproductive techniques? Would you induce ovulation with time? Or you would just do conservative management and follow up and reassurance? Can you please answer in this particular case? Assisted reproduction, 7.1%. The maximum was 50%. Went for IUI, 37% induction of ovulation and timed intercourse, and 7% reassurance and follow-up. Okay, type. Of course, I would believe that going for assisted reproduction is not the right time to go for assisted reproduction. هي مش هتروح في حتة, بس هي she's still young and no need to proceed for ART just because. Other one. Now, what about induction of ovulation and timed intercourse? Do you believe, I really want an answer for this, do you believe that for 2 years it wasn't really appropriate for during her sexual life to have really an appropriate time at the time of ovulation, pre-ovulatory or a time of ovulation, and that timed intercourse would be of benefit? And I'm not saying, أي حاجة, this presentation is not being yes, right or wrong. I'm just interacting according to the experience. I believe not. I believe in for 2 years مش معقول ما حصلش انها صدفت at the right time ان حصل intercourse with يعني this semen whatever يعني. I think this is not the right time to tell her okay let's go for time intercourse. Type, would you induce ovulation just for the time intercourse? Well, I believe also that 1 egg is like 2 eggs is like 3 eggs. Increasing 1 or 2 eggs at ovulation, I don't think this will really increase the chance of getting pregnant in a naturally and regularly ovulating female. ولا تركوا رأي تاني. I would go for intrauterine insemination, and this is exactly what happened. عايز أغير ما بيغيرش. السؤال اللي بعده. نعم. Yes, they put it, yes, okay. But conventionally and classically, assisted reproduction means handling an egg. This is the classical and traditional definition of assisted reproduction. Yes, and because we do IUI, pre-ART or whatever indication, they just put it in as a part of assisted reproduction. Now? Yes, okay, but you would go for يعني IGZI, IVF and IGZI. I think we'll go for intrauterine insemination.
احنا ممكن نسأل يا دكتور.
Sure, of course.
يعني في there is indication for IUI.
Sorry?
Indication for IUI. يعني severe male factor infertility is not an indication for IUI.
Exactly.
يعني and the definition of severe male factor, if the count is less than 5 million, don't waste the time of the patient, don't waste the money of the patient, and direct for IGZI. If the
anyway sorry
يعني لو كان العدد، انت ما قلتلناش العدد كام حضرتك؟ اقل من 5 مليون لا ما تعملش اي اي.
لا سوري الانديكيشن فور اي او اي از mild to moderate asthenospermia or oligospermia asthenospermia. Marked no it's not an indication for intrauterine insemination. It's an indication for assisted reproduction. اما اقول mild asthenospermia meaning that the motility, the progressive motility is not less than 20%. This is mild asthenospermia. And the count from mild to moderate, دلوقتي traditional count او accepted count is more than or equal to 15 million per milliliter. ده بالنسبه للكاونت.
يس. لو اقل من 5 مليون ما نعملش اي او اي، على طول نعمل اكزي.
Yes, exactly. And I will use my نعم. He's been managed for the past few months. He has been taking treatment for the past few months. Maybe I didn't mention it.
At least it's from 3 to 6 months. يعني why don't you manage this? يعني I put this point in my mind. يعني.
Yes, you are right. ممكن ياخد بس هو already خد قبل كده treatment with andrologist. He didn't do an effect.
Failure of the management
yes,
of male
sure.
factor must be written. Yes, thanks.
I started my okay. Now anyway, the couple decided to go for a trial of IUI before going for assisted reproduction. Type. In this case, I'm always discussing this case, not in general. We're discussing this case. So the question number 2, which protocol would you choose for intrauterine insemination in this case? Is it clomiphene citrate alone? Is it letrozole? A combination of clomiphene with HMG or FSH. Just go for FSH and نعم. انتوا بتغيروا من عندكم ولا حاجه؟ ما عشان كده ما لسه طيب ماشي اوكي. FSH HMG or go for a natural cycle. %, is clomiphene citrate with FSH HMG. Very well. And natural cycle, 13%. Clomiphene citrate alone, 13%. And the others, 6.5%, is letrozole. Very well. This is a good answer, actually. But in this case, in this patient, okay, she had a good antifollicle count. أنا عايز أغير. She started actually clomiphene citrate alone. ما كناش عايزين too many follicles. وكان الانترافوليكل count بتاعها قلت 16. It's a good antifollicle count. Probability of responding to this dose of clomid is high. So she started clomiphene citrate. 100 milligrams per day from day 2 of the cycle for 5 days. ولما عملنا لها monitor ovulation by day 12 كان في 2 leading follicles more than 18 or equal to 18. But her endometrium was echogenic. The insemination was performed 42 hours after HCG, 5,000 units. The processing of semen was perfect, but she did not get pregnant.
IUI was
Yes. You can do IOI 36, 42. يعني it's not really, I think it's not very classical when to do the IOI. You don't have to do the IOI before ovulation or after. Sometimes you do IOI twice in the same cycle, before and after ovulation. For my experience, لو في male factor, I prefer to do IOI actually after she ovulates, actually, especially لو كان في mild asthenospermia or oligospermia. لكن لو كان هي المشكلة في الأوفيليشن I would prefer to go for before ovulation. نعم.
Can I have a comment?
نعم.
الدكتور النشار قال ان at the time of ovulation لو حصل انتركورس حتى بعد الاوفيليشن بعد التريجرنج هو المفروض يكون الاي او اي تايم، فانا شايف كده انه اتاخر الحقيقه.
انا هقول اتي احنا usually we are doing the IOI 34 hours after ال HCG، لكن الكوكرين سيستماتيك ريفيو قارنت ما بين 24 و 48 وجدت بان there is no difference، فاللي عمله الدكتور ايهاب ده صح. لكن انا لو كنت منه ما كنتش هدي كلوميفين ستريت وكنت هدي ال HMG. وصل؟
لا معلش
انا اسف. دكتوره عفاف، اتفضلي يا دكتوره عفاف.
يعني عندي بنت صغيره عمرها 22 سنه وعندها regular cycles بلس الهرمونال بروفايل اتس فيري كومبتنت، والمشكله عندها في الميل فاكتور. ليه ما ستارت بالناتشورال سايكل؟
You can start with definitely go for a natural cycle, but the references all on the scientific publications mention that giving induction ovulation increases the chance of a successful trial of IUI with induction and not natural cycle. This is the evidence-based actually.
Yes, I quite agree with you, Dr. Ihab. There is no role of the natural cycle at all لما أكون بعمل IUI. وحكاية التايم وده الكلام ده evidence based و recommended by الكوكرين. اتفضل دكتور عبد الجواد متولي.
Triggering ovulation by 5,000 unit. It is better to be done with 10,000 units. What is your opinion?
Actually, 10,000 units was the traditional dose to give, but 5,000 and 10,000, and that's also by evidence. It does not make that difference giving 5,000 or 10,000.
This is quite right.
Okay.
احنا عندنا وجدوا بان مفيش فرق ما بين 5000 و 10000، لكن وجدوا الاتي: الناس اللي بيعملوا to decrease the dose of HCG عشان يمنعوا الاوفير هايبرستيميشن سندروم، وجدوا the least effective dose of HCG كام؟ 3500. الليست افكتيف دوز في حالات البوليسيكوفر سندروم 2500. اتفضل يا بيه.
طيب. Now that she didn't get pregnant, the problem with mentioned before that the endometrium was echogenic. I just want to know, Dr. Walker mentioned it في البرزنتيشن بتاعته اللي قبليها. What is the appropriate endometrial thickness for implantation, whether in general or during assisted reproductive techniques for embryo transfer? 4 to 7, 8 to 12, 12 to 14, or 14 to 16 or more.
السؤال بقى، هات السؤال علشان
بيجاوبوا.
طيب اصل انتوا المفروض بان هو يبقى فيه 1 2 3 4.
هيجي دلوقتي.
ايوه كده صح كده.
بالظبط. هو actually 8 to 12 is the appropriate endometrial thickness for implantation. 4 to 7, this doesn't mean that you'll not get pregnant, but the chances are less than this measurement from 8 to 12. 12 to 14 still they get pregnant, but it's not the appropriate the best measurement. Of course, above 16, we see frequently that these patients have what we call polypoidal endometrium very often. And that is why I would like to I would like to mention حاجة مهمة قوي for the practice. This is what we call an echogenic endometrium. هو مش المفروض يكون كده pre-ovulatory. This is echogenic and thick. This
is what we
It's the
want
best.
during the late proliferative phase, the pre-ovulatory phase. It's the trilaminar endometrium.
Yes.
The one, it's 3 layers, 2 layers, this layer and the one below. This is the basal part of the endometrium, and the hypoechoic part, this is the functional endometrium. And what's between is the interface between the 2 layers. And not only this, this is a very nice trilaminar endometrium, the late proliferative pre-ovulatory. And I believe it's the best time to assess the endometrium is in the routine checkup, is pre-ovulatory and not following menstruation. ليه؟ دي نقطة مهمة بنشوفها كتير. بنشوفها كتير لما يجي لنا reports ان عاملين تشيك اب وفي من ضمن الريبورتس عامله الترا ساوند بوست menstrual بيقول everything is fine. لكن actually the problem is in the best time to diagnose the polyps is pre-ovulatory in the late proliferative phase, because polyps appear echogenic and the trilaminar endometrium is hypoechoic, and this is the best time to diagnose it. وفي الحاجة الثانية إن post menstrual على طول the endometrium is thin and the polyps are also thin. They increase in size and thickness together with the thickening endometrium. So this is the best time to diagnose endometrial polyps. This is for the practice during the pre-ovulatory phase. والحاجة الثانية برضو أحب أقول برضو نقطة بس كده for practice، ودي اللي احنا بنعمله النهارده، ان لما يجي برضو assess the ovaries. برضو when is the best time to assess the ovaries؟ نعم؟ day 3 of the cycle. This is the best time to لو انا عملت assessment للاوفرز by day 3 4 5 انا هطلع كل الستات polycystic ovaries. لأن this is the time when all the follicles are being recruited and they are all small. فأنا كده بنطلع we are exaggerating the diagnosis of polycystic ovary. بيقول الست عندك تكاسل مبيض على طول، بتبتدي هي تخش في دماغها الحكاية دي وتفضل في دماغها مدى الحياة. إن هي قالوا لي عندي تكاسل مبيض. ما هو أنا دلوقتي what is the diagnosis of polycystic ovarian disease? I have to have 2 of 3 criteria in order to diagnose it. أنا عندي oligomenorrhea or irregular cycles أو amenorrhea, together with a picture of polycystic ovaries, together with hyperandrogenism. 2 من 3 دول أنا شخص polycystic ovarian disease. طيب أنا عندي regular cycles، واحدة عندها regular cycles وده very common regular cycles، ما عندهاش signs of hyperandrogenism، وفي نفس الوقت بعمل لها assessment للأوفريز على طول post menstrual، أقول لها have polycystic ovary. صح ولا لا؟ بتحصل ولا بتحصلش؟ بتحصل. لكن انا احب اعمل امتى؟ بري اوفيلاتوري اور ان ذا ليت بروليفريتيف فيز، لما الاقي بيج نايس جروينج فوليكل ليدنج فوليكل ده مش وعندها ريجولار سايكل، مش هقول لها بقى كلمه بوليسيستيك اوفريز، هقول لها انت عندك ا جود انترال فوليكل كاونت، جود اوفيريان ريزيرف. ذيس از بس كده ملحوظه بحب اقولها في
الحقيقه انا مش متفق مع حضرتك.
ايوه
انت حضرتك دلوقتي بتعمل diagnosis of the polycystic ovary syndrome by exclusion. انك انت شفت باي اكسكلوجن لما تعملها
نو انا قلت 3 لا 3
انك انت شفت. لا انا بتكلم دلوقتي في فرق ما بين بوليسيستيك اوفري سندروم وبوليسيستيك اوفري. for assessment of the antral follicle count it should be in the day 3 basal، اسمه basal اللي هو يكون بالنمبر ويكون في اليوم الثالث او الرابع او الخامس، واضح؟ وبنقيس من 2 لغايه 10. لو انا شفت بان في واحده ماتيور فوليكل دي معناها بانهاش بوليسيستيك اوفري خالص، ان دي اوفيوليتنج. لكن برضه انا عايز اقول اتي سبقا للكلام اللي حضرتك قلته، بان احنا في عندنا دلوقتي اوفيولاتوري بوليسيستيك اوفري سندروم.
اكزاكتلي
احنا في عندنا 4 سب تايبس اوف بوليسيستيك اوفري سندروم، منها الاوفيولاتوري بوليسيستيك اوفري سندروم. فهي الكرايتيريا او الاسسمنت والكلام ده اللي قالوه الروتودرام اللي هي البوليسيستيك اوفري الترا سونوجرافي بوليسيستيك اوفري، لابد يكون في الفوليكولار فيز ولابد يكون بيزل.
This is for the diagnosis of the antral follicle count but not for the diagnosis.
هو الانترال فوليكل كاونت criteria for the polycystic ovary.
لا يعني يعني disagree بالحته
طبعا
دي
احترم راي حضرتك.
اصل انا I believe in the antifollicular count can be done any time in the cycle. Yeah, you can have a growing follicle, but you can diagnose or count the antifollicular count any time of the cycle. You will have even pre-ovulatory and the late proliferative phase a growing follicle, but all the other follicles atretic, whether atretic or did not continue the maturation, are still there.
Yes. النقطة الثانية which is more important the thickness or the pattern. ايه رأيك يا دكتور؟ الباترن is more الله ينور is more important than the thickness. لدرجة ان في ناس بيقولوا الآتي بيقولوا whatever the thickness of the endometrium لو كان هو trilaminar it is a good it is a receptive endometrium.
Exactly.
موافق حضرتك؟
طبعا انا موافق جدا.
شكرا.
Trilaminar endometrium is very important than the thickness. وقلنا ان في pregnancies بتحصل
انت لقيته خلاص هو ترايلامينر ده ايوه شكرا.
يعني بس انا بقول ان the best time to diagnose endometrial polyps حتى مش بس في الاي او اي او في واحده بتعمل لها تشيك ابس. The best time is حتى بنعمل لها assessment for assisted production. This is what you see كتير قوي at the time of a pre-ovulatory or the late proliferative phase. Polyps are very clear at that time.
Yes.
Now, a second trial on this patient was attempted using recombinant FSH alone. Starting ليه بقى احنا خلاص ما خدت كلوميفين سيتريت وطلع ان هو بيعمل endometrial echogenicity فبالتالي ما نضيعش وقت فيه. Starting from day 2 of the cycle for 6 days. We monitor ovulation started by day 9 لقينا عندها 5 leading follicles ووصلوا more than 80 or equal to 18 millimeters by day 12 of the cycle and a trilaminar endometrium 11 millimeters thick. السؤال عايز اساله في حاجه زي كده والدكتور ابو بكر كان قال المحاضره بتاعته طبعا المحاضره شيقه which dose of recombinant FSH or HMG you would use for induction in this patient عموما for intrauterine insemination. Would you go for 150 units, 37.5, 225 ولا 75 international units in this patient? حلو قوي 62% 75 international units. This is exactly what we gave. The 37.5 is for induction of ovulation in polycystic ovary. This is the recommended dose as Dr. Abu Bakr mentioned. مع ملحوظه ان الدكتور ان one of the references اللي حضرتك قرأتها كانت بتقول ان start for 14 days in the beginning and then increase. بس there is another reference بيقول ان هو only 7 days and if you did not find follicles reaching 10 millimeters or more than 10 millimeters then after 7 days you increase but don't wait for 14 days to increase. Am I correct? Right. Okay. نعم ده في 37.5 this is for polycystic ovary. It's too low to start في واحدة intrauterine insemination أو واحدة have a good antifollicular count. 150 is high. She will get really ممكن يجي لها hyperstimulation syndrome and definitely 225 is not the recommended dose at all to start induction of ovulation for an intrauterine insemination in this case who has antifollicular count more than 16. The right answer is definitely 75 units, and I would go for it. Yes. Luckily, she got pregnant. وكان البيتا اس جي بتاعها بعد 15 days 2123, which is suggesting multiple pregnancy. عادة بيبقى much less than this لما بتعمل first pregnancy test. At 6 weeks gestation بعدها باسبوعين بنشوف الفيتال هارت لقينا عندنا انها حامل في كوادروبلتس 3 منهم with pulsating heart وواحده blighted ovum فهي دلوقتي quadruplets. دي من ال undesirable effects of induction of ovulation is multiple pregnancy or what we call high order pregnancy.
ده كان الالتراساوند بتاعها عندها 3. الثلاثه الكبار دول كان فيهم
في بوينتر يا دكتور ايهاب.
ما مش عارف بس بحب بلخبط.
بيلخبط
ورا. مش مهم. طيب ماشي. المهم دي اللي كانت البلايتد اوفم اللي هي لوحدها فوق ده هي. طيب فهي دلوقتي كوادروبلتس undesirable effect. مش حلوه قوي الكوادروبلتس ولا تريبلتس ولا الكوينتوبلتس ولا السكسوبلتس. طبعا هاي اوردر مش حاجه ظريفه قوي. ليه؟ الشانس ان هي يحصل لها complications are high. So in this case what is your preferred line of management؟ وقلنا عندها 3 with pulsations and 1 without an empty sac. Would you go for conservative management وتسيبوها على اساس ان هي هتبقى triplets تكمل triplets، ولا you would do embryo reduction for 2 pulsating embryos and leave 1 pulsating، or embryo reduction of 1 pulsating embryo خلاص وتسيبوها twins و 1 empty sac، ولا you do embryo reduction of 1 pulsating embryo and the empty sac. اديهم فرصة يفكروا في الحتة دي. هلقى لكم بقى. كده احسن. هو ده بقى ايه اللي بموت الفرس. طيب conservative management واخده اكتر سكور. embryo reduction of 2 pulsating embryos which is second. 32% embryo reduction of 1 pulsating embryo and embryo reduction of 1 pulsating embryo and 1 sac. طيب let's نتكلم في واحد. conservative management 35%. she will be triplets صح؟ في الحالة دي هنكمل pregnancy. نعم؟ هاي صح. ممكن يحصل ممكن. نعم؟
يعني what is the appropriate time for fetal reduction؟
ده السؤال اللي عايزين تقولوا يعني قصدي
عايز اقول كده لان في
هايل
حاجه اسمها فانيشنج توينز، ان انا باي ذا ويك 7 8 بلقى اللي انا كنت شايف فيهم بلسيش مفيش،
او arrested او stopping او الهارت stop beating. في حاجه اسمها fetal reduction, embryo reduction and selective fetal reduction. selective fetal reduction you have to wait until 13 weeks او 11 to 13 weeks لحد ما تعمل الانومالي سكان بتاعها. طبعا ده is difficult ودمه تقيل قوي ان انت تعمل reduction intracardiac injection of potassium chloride ودمه تقيل شويه. ده selective fetal reduction
ما بيتعملش في مصر.
لا بنعمله we do it.
لحد 13
بنعمله على 11 13 we do it. وعملنا مراحل كانت حامل في 5
معلش ان ذا فيلد في اي في اف في حاله زي حضرتك دي.
نعم
الحاله ديت في الاي في اف بنقابلها كتير، والاوبشن اللي هو نمره اللي هو ريدكشن انتو 2 بالسيتنج از ذا بيست اوبشن. وبرضه زي ما حضرتك قلت عن 6 ويكس اور 7 ويكس ممكن نعمل ايزي فيتال ريدكشن باي سكشن ايفن، لكن later than 8 weeks
suction.
Suction. Yes. I'm doing myself.
Suction you mean cervical trans-cervical ولا
trans
vaginal زي الاكولكشن يعني. you mean aspiration
يعني I mean aspiration or suction. The whole embryo will come without any
ده for sure. هو صغير بيطلع في الإبرة على طول.
After 8 weeks
it is not sure يا دكتور إيهاب. لا أنا I don't agree with this. مفيش حاجة اسمها aspiration of في الفيتال ريدكشن. في عندنا طريقتين واخد بقى او 3 لو احنا هنتكلم، ودي برضه محاضرة ليا على الميثودز اوف فيتال ريدكشن. اول حاجه زي ما قال تفضل الدكتور ايهاب ان انا بستخدم البوتاسيوم كلورايد. تاني طريقه ان انا اعمل اسبيريشن اوف ذا كاردياك الهارت. تالت طريقه الراجل الاسباني اللي عملها اونلي بانكشرنج. لو انت عملت اسبيريشن وانت ما كنتش جوه الهارت يو ويل لوز everything. وحالات كتيره قوي ان هو ذا بريجننسي ويل كونتينيو رغم بانك انت عملت اسبيريشن وقعدت تمخور في الفيتس. فاحنا عندنا 3 طرق: بوتاسيوم كلورايد ان احنا نعمل اسبيريشن للكاردياك بالسيشن لغايه لما يبقى فيه مفيش بالسيشن، او الراجل الاسباني اللي بيعمل بانكشرنج بس يقعد يطلع ويعمل فين في مكان الهارت.
بس عايز اكومنت على حاجه معلش عشان اسئله على الاجابات يعني. اما انا those who ما هو فكره انا ما فيش حاجه من دول غلط، انا بتكلم انا عايز اعرف when you say conservative management this means that you might get only two continuing the pregnancy, one might arrest, or the three might continue pregnancy and a very high chance to get later miscarriage or preterm labor with the consequences of preterm labor على ال babies. Early and remote complications. This is one of the good answers ودي بتحصل كتير وبيشنتس بيرفضوا ان هم يعملوا في embryo reduction، بسميها هنا embryo reduction، لسه ما دخلش fetal reduction، وقليل طبعا اللي بيكملوا ل age of maturity بالنسبه للفيتسز. ف this is one of the حاجات management you would do. Okay. وهي خدت حقيقة أعلى سكور. The second one اللي هو embryo reduction of two pulsating embryos leaving a singleton. This is one of the options اللي احنا حقيقي ما بنحبهاش قوي. لأن أنا هشفط اتنين واسيب أو هموت اتنين واسيب واحد، أنا لسه ما وصلتش أعرف إذا كان ده this is a good embryo or not. لازم أستنى لحد إيه ما أعمل ال anomaly scan ال first trimester anomaly scan. وفي نفس الوقت هو لسه ما نعرفش اذا كان هيكمل البريجنسي ويوصل للفيرست تريمستر انومالي سكان ولا لا من اساسه. فكده انا ممكن هو كمان يحصل له وات ايفر بقى ايه القلب يوقف كده ضيعنا ايه الثلاثه كلهم. طب نيجي على الامبريو ريدكشن of one pulsating embryos we're leaving two. This means I'm leaving twins, which is I think the most accepted بالنسبه للبيشنت بالنسبه للكابل. انا عايزه توأم وكلهم بيبقوا عايزين توأم سواء عملوا اندكشن او عملوا اي في اف، ويا سلام لو كانوا عملوا اي في اف وحملوا في توأم يبقى كده خلصوا ايه الموضوع في مره واحده. embryo reduction of one pulsating embryo on one empty ما اعرفش ملوش اي معنى حقيقي ان انا اشفط الامتي ساك واخد واحد تاني واسيب الاثنين تانيين. لكن انا بس ملحوظه على الدكتوره ابو بكر قالها اللي هو ان انا ما فيش حاجه اسمها اشفط الامبريو حقيقي at 7 weeks وقبل 8 weeks just مجرد ان انت تعمل تخش في الساك وتعمل اسبيريشن بالسرنجه تلاقي الامبريو كله دخل جوه البتاع وخلص. This is it's very easy actually and waiting actually.
النيد اللي حضرتك بتستخدمها شكلها
بتاعت الايك كولكشن، هي بتاعت الايك كولكشن.
لا
هي بتاعت الايك كولكشن.
اللي عايز اقول الاتي الكلام اللي قاله الدكتور احمد ان هو the best time for vaginal fetal reduction او embryo reduction 7 أسابيع ونص. خلاص. الحاجه الثانيه ان احنا في عندنا some tricks لو انت بتعمل بقى fetal reduction انك انت لابد تبقى شور بانك انت جوه الفيتس، انت ممكن تكون انت وراه، فلابد بانك انت تتحرك بالنيدل بتاعتك يمين وشمال، واخد بال حضرتك؟ لو اتحرك معاك اشفط، وانت ما تشفطش الساك، اياك تشفط الساك. لو انت شفطتش الساك عمرك ما هتشوف حاجه. انت داخل في الكاردياك بالسيشن وتبقى انك انت متاكدت بانك انت قتلته. اتفضل يا بيه. يا فندم. ايوه. وتحاول بانك انت تكون في الحته بتاعه الهارت. شكرا دكتور احمد.
Anyway, this patient عملنا لها fetal reduction, embryo reduction. At 7 weeks gestation, عملنا embryo reduction was performed for one pulsating embryo, leaving twin pregnancy and the empty sac. At 9 weeks, a repeat scan showed 2 normally growing embryos, كانوا ماشيين كويس قوي. And the empty sac was still getting bigger. وطبعا دي حاجة بنعمل لها ignoring. الساك ما هي فاضية ما فيهاش حاجة، بس هي في الآخر ال 2 embryos were doing well. عملنا لها كل laboratory tests، واحدة ست حامل everything was fine. كان عندها moderate emesis gravidarum والعادي جدا زي أي ست حامل والدوخة والحاجات دي كلها. خدت anti emetics ومالتي فيتامينز and routine antenatal care or prenatal care was commenced. First trimester anomaly scan at 13 weeks showed 2 normal fetuses and an enlarging third sac at the fundus. الانومالي سكان باين بنشوف النيوكا ترانسلوسنسي، بنشوف النيزل بون، كران رامب لينث، داكتس فينوزس اند ترايكاسبيد ريجيرج. ورت ان هي في 2 حلوين جدا، وفي another sac في الفاندس has a characteristic ultrasonographic pattern. And this was confirmed by expert gynecological sonographer blind-ended. بعتها له قلت له بص شوف العينه دي هتدور فيها ايه، لقيت فيها ايه، وهو الدرس اللي شفته هو اللي شافه بالظبط. ايه اللي شافه بالظبط؟ البيكتشر دي. This is very characteristic. نعم؟ طب تطفي النور؟ ما اعرفش، مش عارف، ممكن نطفي النور على فكره لو الصوره مش باينه. ها؟ طب دي باينه؟ نعم؟ لا هو حقيقي ده الامبريو، ده الامبريو، وهي دي الكاركترستكس اللي احنا بنبص عليها، اللي هي قبليها اللي هي دي. انا يهمني اللي احنا شايفينها دهيا ايه. المهم هو ده بالظبط اللي اتحقق. انا بقى السؤال اللي جاي بقى، what is your differential diagnosis for this case? Is this a degenerated fibroid? Is this a complete hydatiform mole? Is this hemorrhage in the empty sac? Well, is this partial hydatiform mole? دي البيكتشر اللي بسميها ايه؟ بس اما اخلص الاجابات تطلع. 6.7% degenerated fibroid, 13% hydatiform mole, hemorrhage and cyst, a partial hydatiform mole. Okay. الأغلبية partial hydatiform mole. What is partial hydatiform mole? It is fertilizing an egg, a normal haploid egg with 2 sperms. بدي في الآخر triploid embryo. 2 from the father and 2 from the mother. وده معناه ان الانوماليس بيبي. And what is a complete mole? Is paternal only and no maternal. Okay. اكبر واحده جت 66% اللي هي partial hydatiform mole. بس actually this is wrong. it is not a partial hydatiform mole. ليه؟ الهيستوري احنا قلنا ايه؟ كل ساك سيبريت عن الثانيه. الساك دي كانت لوحدها وبتكبر والامبريوس التانيين بيكبروا لوحدهم، فهي it's a separate sac. اوكي؟ ف this was a complete hydatiform mole coexistent with دلوقتي twin pregnancy. عايز ارجع تاني؟
صعب قوي الحل.
لسه شفتش حاجه
لسه كمان.
فايه
دكتور ايهاب معلش،
نعم
ممكن تعليق؟
اعلي ايه؟
تعليق بس كومنت.
تعليق.
حضرتك احنا في الاكسي ما بيحصلش ابدا ان احنا نحقن 2 سبيرم ان امتي فوليكل.
دي اي او اي.
سوري.
دي اي او اي. اوكي. وعلى فكره سوري، في الاكزي انت ممكن يجي لك complete hydatiform mole. duplication of the haploid paternal sperm, duplication of the genetic material, chromosomes. It happens. It's recorded. قصدي mentioned in the literature. المهم دلوقتي هي شخصت كده وعملنا لها سيرم PTSG طلع 635,000. Very high. And the diagnosis of complete hydatiform mole coexistent with live twin pregnancy was confirmed. طب حاجه زي كده طبعا مش بنشوفها كتير. هي كونسلتد بقى بروفيسورز، ورحت للدكتور محمود حسين الله يرحمه، ورحت مش عارف مين، وقلت له انا عندي كذا كذا اتصرف ازاي، ودخلنا على النت ودخلنا على الليترشر ونشوف بقى ايه الكوردد كيسز، وكانت قصه كبيره قوي. كل ده اتشرح للايه؟ للكابل يعني. طب the preferred management would be دلوقتي conservative management ولا termination of the whole pregnancy ولا نديها intramuscular methotrexate ولا trans abdominal aspiration of the mole ولا local methotrexate in the mole. دلوقتي 13 اسبوع. احنا شخصناها 13 اسبوع لما عملت الانومالي سكان. ماليش دعوه. ها يا جاوبته؟ اكتر واحده termination of pregnancy وبعديها على طول الا conservative management، واقل واحده اللي هي ايه؟ اللي هي intramuscular بس في لوكال ميثيوتروكسيت 7.1% وترانس ابدومينال اسبيريشن اوف ذا مول. اوكي، ترانس ابدومينال اسبيريشن اوف ذا مول از مالهاش اي علاقه خالص بالموضوع خالص. وي دونت دو حاجه زي كده، مفيش حاجه اسمها كده، لان انت هتشفط المول. طب وبقيه التروفوبلاست ديزيز اللي هي invading الديسيدوا. We cannot do such a thing. And there is nothing called local methotrexate in the vesicular mole. It's either aspiration or termination of the vesicular mole ولا suction of the mole ولا لا. طيب تبقى دلوقتي ان انا intramuscular methotrexate I am doing دلوقتي فيتوسايد اللي هيموت لي الفيسيكولار مول اللي هيداتي فورم مول دي، يبقى هيموت التو بيبيز. يبقى من الاول كنت اعمل ايه؟ من الاخر termination بدل ما ادخلها في السايد افكتس. لا conservative management. اوكي طبعا يعني عايز اغير اللي بعده هما the safest for her is to terminate the pregnancy for sure. This is the safest for her. في complications ممكن تحصل مع الهيداتي فورم مول كلنا عارفينها، بس هما they offered the option to terminate the pregnancy وقالوا لا احنا مش عايزين terminate the pregnancy، احنا عايزين نكونزيرف شويه ونكمل. طالما هي ميديكال ترمينيشن طب ما نكمل شويه، هيحصل ايه؟ كويس، حقهم. We cannot force anybody to do anything. عملنا سيرم بيتا اس جي على 17 اسبوع وصل 1.4 مليون. And the patient had mild vaginal bleeding and the mole slightly increased in size. بس هو كل كان عندها ايه الكيسنج بيتا اس جي mild vaginal bleeding with the mole increased in size. اوكي؟ دي البيكتشر بتاعتها على 17 weeks. With another picture 17 weeks. At 20 weeks the mole غريبة جدا appeared thinner، ابتدت ترفع and regressing in size. Both fetuses were doing well. The second trimester anomaly scan was normal but one placenta لأنها بريفيا. ما هي الموضوع مش ناقص بقى، ما هو كملت بقى يعني هي ناقص كمان يبقى كان فيها بلاسينتا بريفيا كمان. عملناها على 20 اسبوع بيتا اس جي لانها بدا بعد ما كان 1.25 مليون بقى 748 ونزل بعد 22 ويكس ونزل 25 وبعد 28 اسبوع بقى ايه 328,000 ايه كويس حلو قوي لحد كده احنا ماشيين كويس قوي وقلنا بنشكر ربنا. وده كانت البيكتشر بتاعت اللي هي المول getting thinner. احتمال يكون من الجروينج ساكس اللي حواليها or they are compressing it whatever، لكن هي it was getting compressed. بس الحاجه الغريبه ان كان البيتا اس جي بتاعها بينزل مش بيعلى رغم لما وصل 1 مليون وشويه. At 31 weeks the patient had an attack of moderate vaginal bleeding وفاكر كويس قوي كانت الساعه 3 الفجر وكلموني احنا نازل علينا دم. قلت لها روحي على المستشفى. دم قد ايه؟ لا دم كلاكيع. طب روحي على المستشفى وكلمنا النايب ولا حضر سيزيريان سكشن immediate سيزيريان سكشن. كان ده بلاسينتا بريفيا ما ننساش it was not complete previa it was covering the internal os يدوب بس بقيتها not covering. كان شويه عندها contractions يعني and she was immediately transferred to the hospital وحضرناها for immediate cesarean section والكلام ده كله. ف what will be the most appropriate method؟ انا كنت محضرها for immediate cesarean section but what would you do in this case لو هي جالها شويه vaginal bleeding at 31 weeks؟ Would you terminate immediately? Would you conserve with tocolysis and corticosteroids? Or would you conserve for at least 48 hours with tocolysis and corticosteroids? نعم؟ جاوبوا ماليش دعوة جاوبوا انتوا ليه بتجاوبوا؟ جاوبوا بس جاوبوا. هو احنا خلصنا البرزنتيشن؟ مودريت. لا انا قايل مودريت قلت مودريت. مفيش ماوس في مودريت في فاجينال بليدنج برضه. ها جاوبتوا؟ طيب انتوا بيرفكت. هو اخذ اكتر سكور الاثنين زي بعض conservative management with tocolysis and corticosteroids or terminate after 48 hours بعد ما تدي وعلى فكره corticosteroids by evidence دلوقتي يعني حاجه approved ان even one injection حتى لو اديتها قبل الولاده ب 12 ساعه it's beneficial for the embryos for the babies. يعني مش لازم زي زمان لازم ادي كورس بعدين استنى كام يوم. اي حاجه corticosteroids بياخدوها الانفنتس is beneficial. ف why not tocolysis for placenta previa يا دكتور عفاف؟ why not tocolysis for placenta previa؟ هي عندها إلى contractions وعمل separation. why not give her tocolysis؟ فاحنا دلوقتي وصلنا ان هي equal tocolysis وحاول نشوف يحصل ايه ولا terminate after 48 hours بعد ما الافكت اوف corticosteroids يشتغل بس التوكوليسيس ياخرها بس 48 ساعه صح؟ اقل واحده خدت ايه سكور هي immediate termination by cesarean section. المهم this patient بقى كويس was prepared for emergency section 31 weeks مش هيحصل حاجه وهيحط في الحضانه وبتاع بس هيعيش. however على ما وصلناها الاوضه واحنا بننزلها في الترولي على وسط العمليات قاعدين مستنيين كده بنبص مفيش ولا نقطه بتنزل بعد كده. قعدنا في اوضه العمليات لمده ساعه مفيش ولا نقطه دم بتنزل. فوقفت. In this case كان لها الاتوزيبان which is the only antagonist for oxytocin. ادينا لها infusion وادينا لها corticosteroids زي ما most of السكور اتاخد واخدناها في الاوضه وبعد لمده 7 ايام not a single drop of blood. فمش قعدتها في الاوضه بقى خرجناها بعد 7 ايام with complete bed rest. Elective cesarean section was performed at 37 weeks with delivery of 2 healthy girls 2.9 kilograms and the degenerated mole اللي قلنا عليها degenerated بقى كانت being compressed was easily separated وكان 9 في 7 سنتيمتر ما كانش فيه sign of invasion of the myometrium. This is the picture of the degenerated mole بعد ما طلعت ودي البلاسنتي ودي الباثولوجي ريبورت diamnonic fused dichorionic placenta negative fundal placental tissue degenerated hydatiform mole negative for invasion or choriocarcinoma. Uneventful postpartum period return to baseline levels within 10 days. mini pill was prescribed لمده سنه ما كانش عندها اي elevation of the beta SCG. دول البنتين اسمهم ميريام وليديا ودول بعد ما وصلوا 3-4 سنين ودول السنه اللي فاتت وزي ما قلت لكم كنت بسميها هابي ليدي عشان امهم هي اللي في النص هي اللي طول الوقت مبتسمه الابتسامه دهيا. كويس؟ طيب وده اللي حصل والحمد لله كل حاجه مشيت سليمه بس هي من ساعتها شعري ابيض شويه هو كان اسود من كده شويه. طيب نيجي الدسكشن بقى which is very interesting ايه التوين يعني في الاخر ايه توين pregnancy عايز اقول بس حكايه ان الكيس دي مش هتعدي علينا كتير. It is not a usual case. In a twin pregnancy with complete hydatiform mole and coexistent fetus resulting in a live birth is very and extremely rare حقيقي. Only 56 cases has been reported in the literature. A total 200. بس only 56 reaching a live birth. And the longest pregnancy duration reported in the literature was 33 weeks. Possible maternal complications associated with molar pregnancy are high, including early onset preeclampsia, herpes gravidae. كلنا عارفين كل الكومبليكيشنز اللي ممكن تيجي مع complete hydatiform mole. When the risk of وبرضه الريسك of persistent trophoblastic disease لما بيكون لوحده اقل من لما يكون مع pregnancy with a coexistent hydatiform mole 56% to 20%. دي بقى to our knowledge ان this is the first case of complete hydatiform mole coexistent with a normal twin pregnancy مش واحد twin pregnancy. وكانوا الاول لو كانوا كملوا كانوا هيبقى ايه triplet pregnancy reaching full term. تعملوا elective C-section at 37 weeks. Also unusual in the mole degenerated and did not progress. فin conclusion بقى ايه؟ الفكرة in the past the coexistent twin pregnancy with a coexistent hydatiform mole was terminated immediately على طول because كان النولج natural history knowledge بتاع natural history of the progression of this complete hydatiform mole was not there وكان مهم في الآخر إن هي to terminate pregnancy. بس things changed recently شوية in pregnancy can be continued when fetal anomalies and abnormal karyotype are excluded. ما تبقاش ابدا ان هي تكون partial mole. طبعا you have to make sure ان this is not a partial mole وان البيبي is no abnormal karyotyping. But close surveillance to detect potential early signs of maternal and fetal complications is compulsory, and detailed discussion and informed consent with the couple is necessary. This is very important. لازم تقول كل المشاكل قبل ما تقول لا 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 ان شاء الله الحمل هيكمل وهنستنى. لا 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 ما انت مش شغلتكم خالص. انتوا تقولوا ايه العكس تماما. تقولوا ان الدنيا سودة في الحاجات ده هي الدنيا سودة وهم اللي يرفضوا ان ايه يكملوا الدنيا سودة. فانتوا كده خلصتوا ذمتكم وخدتوا informed consent. This is a very serious case. Thank you very much for your patience.
We would like to thank Professor Ehab for this nice and interesting case. To come to the termination of pregnancy في coexistent complete mole is not recommended, and we can conserve the patient, but the termination if there is a congenital fetal malformation, if there is a severe vaginal bleeding, or if there is preeclampsia, severe preeclampsia. شكرا يا دكتور. The last but not the least, Dr. Jan will address accelerating GMP manufacturing yields and the economics of therapeutic FSH, a case study supporting broader patient reach. Dr. Jan.
Thank you very much. I hope you are still patient and still have some energy to listen to a more technical talk now, because I will introduce the manufacturing process and the process economy of the production of Gonapure. Thanks to Professor Nashar, he introduced already the advantages of recombinant gonadotropins, or in this case particularly FSH over the urinary version. So I will concentrate on the manufacturing process and the economy of the process. The content of my presentation today will be as follows. I will begin with a short introduction of Minapharm and its subsidiary, its biotechnological subsidiary, Rhine Minapharm. I will talk about the Gonapure process, how we produce it, the product here in Egypt, the economy, as I mentioned, and of course, very importantly, I will address the quality of the drug and eventually come to my conclusions. Minapharm decided about 18 years ago to invest and to enter the field of biotechnological medical drug production, and it did so by establishing a joint venture with a German-based company called Rhine Biotech, based in Düsseldorf, and the resulting product was the company called Rhine Minapharm. So the name was combined from these two companies. Rhine Minapharm is dedicated to research, technology development, and know-how transfer for genetically engineered recombinant products to achieve, and this is very important, affordable local medicinal products. Rhine Minapharm was and still is the first Egyptian and Middle East biotechnological company that is doing development as well as production from the cell to the finished product. On this slide, you see a timeline of the history of biotechnology, starting out in 1998. The first discussions with between Rhine Biotech and Minapharm took place. In 2001, Rhine Minapharm was established and finalized, and in 2003, the production and research facilities have been erected. As early as in 2005, the first product, it was the native interferon alpha-2A used for treatment of hepatitis C, was launched to the local market, and only 1 year later followed by the more innovative and cost-effective version, the pegylated interferon alpha-2A that you know under the brand name Rivaroxaban. In the same year, the R&D facilities, the R&D labs have been finalized, and further products based on the active ingredient hyaridine, a parenteral version, and topical versions of this antithrombotic have been launched. All these products were based on a yeast, on a microbial yeast, Hansenula polymorpha. In 2010, there was a unique step. Minapharm, as an Egyptian company, acquired a German company, Probiogen, based in Berlin. This was, of course, a strategic move, and in the next slide I will tell you why. And in 2013, the first product from mammalian cell culture was launched. This was the Gonapure, the product that we are talking about today. And this is a product that was developed in our research facilities in Egypt and produced in Egypt. As I said, the move to acquire Probiogen was a strategic decision. And why did we do this, or why did we make this decision? The goal or the aim was to expand and complement our R&D and manufacturing facilities and capabilities. And Probiogen was seen as a perfect candidate because they have more than 20 years experience in cell line development using classical as well as innovative expression systems. They have a very broad know-how in process development from lab scale to production scale. They are GMP certified contract manufacturer according to EMA and FDA standards. They are using disposable, so very innovative fermentation technology, which we're also using. I will come to this later. And they give us access to very interesting innovative technologies, like, for example, new cell lines for product development, like tools for, like the Glymax, with which you can optimize or modify glycosylation patterns, so the attachment of carbohydrates to protein structures, or also very interesting, the artificial lymph node. It's kind of a system that you can use to test the immunogenicity of drugs or drug substances outside the patient, but the result will reflect exactly what is going to happen inside the patient. This acquisition was well recognized in international literature. Now, our facilities in Egypt, in Tents of Ramadan City, biotechnology facilities, we work according to WHO standards. We are certified by various quality certificates. We work in classified controlled areas. We have 2 production sites, each 600 square meters large. We separate our 2 expression systems. I told you we have yeast expression system and we have a mammalian cell culture. We do not mix these cell types to avoid cross-contamination. So each of the cell expression system has its own production area. Overall, in biotechnology, we have 80 employees, and we work with different technologies in production, in the fermentation. For the yeast, we use the classical standard stainless steel fermentations. And for the mammalian cells, we use the disposable systems, which are quite innovative. For the technology, our technology is worldwide patented, so we have a secured access to this technology. We're working with proprietary mammalian cell culture systems. Our Hansenula system, the yeast system, is also very innovative, and both mammalian cell culture and yeast system have shown to have a global reliability, because they have been used by other companies worldwide also to produce certain products. We're not alone. We need, of course, some backup, some support. We have established a very broad bioalliance network, that's how we call it. So we work together on different levels with different companies or academic partners. Of course, ProBiogen is one of the leading partners that we have, but as you see, there are also others involved at different levels. For formulation development, we work with different universities. But the biggest collaboration between Rhein-Mina-Pharm or from Rhein-Mina-Pharm is with its mother company, Mina-Pharm. And I will tell you why. Rhein-Mina-Pharm is not producing a finished product. They're not producing the drug. They're producing the drug substance. So they are using the cell, they're doing the fermentation, they're purifying, so they're eliminating all contaminants from the target protein, and eventually they use this target protein for formulation or send the protein directly to Mina-Pharm. Formulation is taking place at Mina-Pharm, as well as filling and packaging, and then marketing is following. So Rhein-Mina-Pharm produces the drug substance, Mina-Pharm produces the drug product. Overall, and this rounds up my short introduction, these are the products that Mina-Pharm has launched from the biotechnological section. Interferon alpha-2A in different strengths, 3 and 6 million, the pegylated version of interferon alpha-2A, rifampicin, the antithrombotic Hyrodine in a parenteral as well as topical forms, and as you know, Gonapure, the recombinant follicle-stimulating hormone in 2 strengths. So let me come to the second part of my presentation, the main part of the presentation concerning Gonapure. Just a few facts in the beginning. You may all know, of course, that this is a recombinant human FSH. It was fully developed and is manufactured from the cell to the finished product in Egypt. It is produced in mammalian cells, so-called CHO or CHO cells, which stands for Chinese hamster ovary cells, which are used since the 50s of the last century for protein expression. So they have a very long and documented history. We have a 7-step purification process to eliminate all contaminants. The lyophilization is a freeze-dried powder form, and we have 2 strengths, 75 and 150 international units. Here is a process overview. I will not go into much details, and you do not have to remember all of this. I just want to highlight the major aspects for you. So we start out with a vial from a cell bank. It's a very small vial. This has actually been produced by ProBiogen and transferred to Mina-Pharm. So we use this when we start a production batch. We defrost it, it's frozen, and we expand the volume. This vial contains about 6 million cells, but this is of course not sufficient, like in this small container, to do production. So we need to expand, we need to increase the volume. And this is done to up to 200 liters in our labs, so that we have at the end the full-scale production fermenter. In this fermenter, then, the production takes place, the production of the target protein, and we use this and we purify it in a 7-step process, as I said, mainly a combination of chromatography and filtration steps, and we end up with a purified target protein. These steps are all taking place in Rhein-Mina-Pharm until we have the drug substance. And then we transfer the drug substance to packaging, and eventually marketing of the product. Again, small vial, 1.8 milli, is expanded first in these plastic flasks to up to about 350 milliliter. From there, it's expanded to this shaking fermentation systems where like sterile bags are inserted in which the cells are incubated. Up to 25 liter can be cultivated like this, and then we transfer it to the production, to the main production fermenter, which has either 50 liter or 200 liters. We had both of them. All these steps are occurring in disposable systems. What you see here are stainless steel holders, but here we insert plastic bags. And the plastic bags are the only material that come into contact with the cells, the media in which the cells are cultivated, and eventually the product. So the product does not come into contact with the stainless steel fermenter, only with a plastic bag. The advantage is you can harvest the product, you sterilize the bag, and you discard it with a normal household waste. So it's a very safe and clean process. Why did we choose this? Why do we choose disposable fermentation technology? Because it offers a lot of advantages, more advantages than disadvantages. First of all, it makes us very flexible. It gives us very short turnaround times. Very important if you have multi-drug facilities in which you would like to produce more than that you have a lower risk of batch-to-batch contamination than if you use classical stainless steel systems. It eliminates a lot of regulatory aspects, like validation issues, because a cleaning process is essentially avoided, because you just take the bag out, you sterilize it, and you discard it, and you do not have to clean the fermenters. And very importantly, in terms of production costs, it decreases essentially the investment in equipment, the investment in utilities, the investment in space and labor. There are potentially also disadvantages, like for example the scale. You cannot produce more than 2,000 liter in a disposable fermenter. This has physical reasons, because you cannot produce bigger plastic bags than 2,000 liters that are stable. And you always have to look at operating costs. But for our process, we are a very efficient process, so the operating costs are not really a disadvantage for us. So there was a clear sign, we go for the innovative disposable systems. Then we purify the process, the product. So we filter the cells from the media. In the media, you have the product, and then we have a mixture of 3 chromatographies with some filtration steps to purify all contaminants away. What we essentially need for products from mammalian cell culture, that is worldwide the case, you need to show the potential to remove viruses. It doesn't mean that the process is contaminated with viruses, but since we are working with mammalian cells, and mammalian cells might be also a host for human pathogens, you have to make sure that they are not there. And this we do by different means. So for example, a detergent treatment which disrupts enveloped viruses, and a special virus filtration. You use filters with very, very tiny pores that do not only retain cells, not only bacteria, but also very tiny viruses. And then we do the formulation, filling, and lyophilization. This is very important. One of the major slides that I would like to draw your attention to. The process optimization, or the process economy. We initially used a 50-liter production fermenter. with a working volume, as you see here, from 45 liters. We had a certain productivity. You do not have to remember and focus on all the data here. And then we said, this is not sufficient. We need to upscale. We need a larger system. So we scaled up the volume fourfold. We went from a 50 liter to a 200 liter system. And you see, instead of 45 liter working volume, we work with 195, which is a factor of 4.4. The productivity in both fermenters is approximately the same. The process duration was also identical, 6 weeks. So, not surprising, we got from a fourfold scale, also fourfold the total FSH produced. However, when we purified it, we found that our purification process was more efficient in the 200 liter scale than in the 50 liter scale. We had suddenly a much higher yield. We retained much more product after the purification from the 200 liter than the 50 liter, with a factor of 1.8. So at the end of the day, when we look at the output of vials, and this is calculated here for 75 units, we find that the switch from 50 to 200 liters gave us not fourfold the number of vials, no, we had more than sevenfold. And this means we're not only scaling up, we also increased the efficacy. Or in other words, today we manufacture, or we make one run in the 200 liter instead of 7 runs in the 50 liter. And this is, of course, reducing a lot of efforts. The last section of my talk is concerning the quality of Gonapure. I will present different data regarding purity, isomer distribution, potency, of course, safety, and pharmacokinetics. The first part, the first purity assessment is done here by size exclusion HPLC. We injected 4 different products. Gonapure in black, Gonal F in blue, Fostimone in green, and Purigon in brownish color. And you should focus on these peaks here. These are the peaks of interest. First of all, you find that they're all retrieved at the same time. They're directly under each other. Also, the height of the peaks is the same. Also, the shape of the peaks is the same. And there are no further peaks detected here in the front. This means we have a very similar behavior in the size exclusion for all 4 products. All 4 show a very similar purity in this assay. We use another assay, the so-called SDS polyacrylamide gel electrophoresis. It's a powerful tool in protein analysis to detect aggregates. This might be important because proteins sometimes have the tendency to form clusters. But also, to make it short, we injected the 4 products, and you see one essential signal here for them, so no aggregates detected for all the 4 products. They show very similar behavior. Then we did isoelectric focusing. This is also an electrophoretic method, separating different proteins according to their isoelectric point, which is characterized by the overall charge. You see very characteristically a band pattern for the products, because FSH is composed out of a heterogenic mixture of different isoforms that have slight differences in the glycosylation pattern. But it's very important to make sure that there are no major differences, because glycosylation can have an effect on the immunogenicity and also, very importantly, on the potency of the product. You see, for Gonapure and Gonal F, we have a very high similarity of the glycosylation patterns. For Fostimon, this is also the same, but the product signal here is a little bit more fuzzy. This can be due to the fact that this is a urinary preparation, whereas the other two are recombinant preparations. Now I come to the potency. And for the potency, we actually employ two different assays. One assay is the one that we have to do, which is requested, which is the pharmacopoeial assay, but it has some drawbacks. And it's not the most modern assay. I will present it. But before I will do so, I will present to you our own developed assay that we apply in parallel. The pharmacopoeial assay is an animal model assay, so it requires to sacrifice a lot of rats. This one does not need any animals. We genetically engineered a cell, making it susceptible for FSH and turning FSH binding to its receptor into an activity signal. How does this work? So we took a cell, we transfected it with the gene for the FSH receptor. So the FSH receptor is exposed on the surface of the cell. And when you now add FSH, to the solution, actually FSH should sit here now and bind to the receptor. Then this binding will trigger a cascade of signal transduction into the nucleus. And it will actually lead to the fact that a manipulated, an engineered gene is expressed. In this case, it's another sexual hormone, the progesterone. That is not the normal case. So it's a manipulated cell. So the progesterone will be produced. It will be excreted from the cell, and it can be detected by a normal commercial ELISA. This is why we chose progesterone, because there are many different commercial kits available to detect it. And the level of detection of progesterone here in this ELISA is directly proportional to the binding strength of FSH to its receptor. When you look at the results, you will find that the recombinant products give the expected result. They're all quite similar. And also expected, the specific activity of Fostimon is reduced compared to the recombinant products. This is also described in literature. So basically, our assay is directly reflecting the expectations. The second assay is a pharmacopoeial assay, also called the Stillman-Poley assay. It's an in vivo assay using rats. It's the only approved activity assay for FSH by Pharmacopoeia, FDA and European Pharmacopoeia. It's more than 60 years old. And it's, I think, only one of the 3 assays that still depend on animals. There are strong efforts to reduce animal usage in drug testing. For cosmetics, this is already completely abandoned. You're not allowed to use any animals in cosmetic testing. And in medical drug testing, it's also reduced. The assay works as follows. You inject rats with FSH, and if the FSH is potent, it will have a growth effect on the ovaries. You dissect the ovaries out, and you weigh them. If FSH was potent, then it was a strong growth effect, then the ovaries get heavier than if the FSH is less potent. You can see already that this assay might be very susceptible for variations. Why? Because you need an extremely skilled operator to cut out this fluffy, soft organs, to clean it, to dry it, and then to weigh it. This means also you need a lot of animals to have a robust statistical readout. More than 40 rats for one single preparation to be tested. However, it works. And when you compare the potencies, you find that all recombinant proteins tested are well above the threshold that has been described for recombinant proteins, whereas Fostimone, as expected, is below. Safety is a big issue, and I told you viral safety is one of the key points that we have to look at. And we do this by many different means. First of all, our cell banks, the master cell bank and the working cell bank, so the vials that we use for the production, they are characterized for the absence of adventitious viruses, so we tested them. We do not use any animal components in the production process. So this reduces the risk that we insert any animal or human viruses. There is a possibility to induce the protein expression by viruses. We don't do so. We also do not use any animal-derived antibody for the purification. And all raw materials are of excipient grade and from qualified suppliers. We also confirmed the absence of the viruses from our fermentation. So we tested it in many different trials, no viruses. And very importantly, this is requested by regulatories, we had to test the capacity of the manufacturing process to reduce viruses. You spike viruses into your sample, then you apply your purification process, and you see that the viruses get reduced, and this went perfectly well. Okay, last two slides. Toxicity was tested. We had, upon high overdosage in animals, more than 600 microgram gonapure per kilogram body weight. Did not show any toxicity effect, so we could conclude that this is a safe drug. And last but not least, we tested the pharmacokinetics, and we see upon injection of subcutaneous as well as intravenous that the three different drugs, Gonapure, Gonal-F, as well as Fostimone, they show a very similar bioavailability in these tests. So let me conclude. Minapharm is a regional leader in biotechnological medicinal product development and manufacturing. We have many, up to 10 market biological products. We successfully implemented the mammalian cell culture. We have a safe and efficient follicle-stimulating hormone. And I'd like to thank you for your attention, and I hope you enjoyed it.
Thanks a lot, Dr. Ray, for this nice presentation. And I think if there is any comments or questions for Dr. Ray. Yes, Doctora.
Yes, please.
Afaf Ismail.
Is Gonapure effective for all types of anovulation, or I have to add little bit LH for some types?
No, let's say Gonapure can be used. I'm not the medical expert, but Gonapure can be used in the same way as you use a Gonal-F, or you can use the Purigone, so as any other recombinant pure FSH drug.
Excuse me, can I direct the
yes,
question to the panel?
I think I answered this question. In the hypogonadotrophic hypogonadism, recombinant FSH, whatever its name, cannot be used alone. for the results.
Thank you.
I think by the question of Professor Dr. Afaf, we came to the end of this very interesting and very useful meeting. We would like to thank all of you, would like to thank all the speakers, and would like to thank Gonabure and Mina Farm. Thank you very much.